Subject today is Puerperium normal. So definitely there will be another class on abnormal Puerperium. By this time, possibly we have been taught lot of things about pregnancy, delivery, and all the things. So after the delivery is over, somebody may assume that risk is over. But no, it is the puerperium during which lot of risks are there. That's why we have to know the period following delivery is also important because of the complications, not only, but because of the long case you will get almost alternate student puerperial case. Because usually pregnancies is delivered, so the cases will not be get, but we will definitely get after the delivery 2 to 3 days hospital stay, or in other cases maybe 5 to 6 days. So those cases will be given in your exam as a long case. So very important. Not only that, you will be taught separately in your clinical classes, the history taking and everything. So in one of the batches possibly I have already I have already taken the class on puerperium, but today is the theoretical part, which is, if you do not know, it will be difficult to follow the long cases. So let us start the puerperium. So these are the headings under which we will discuss what do you mean by puerperium? Changes. What are the changes? Like the physiological changes of pregnancy, then there are physiological changes. So that is the regressive changes which occurs following delivery. So what are the things that occurs? Examination things which will be taught in the ward clinics, and what advice will you give for the mother, and what complications could occur. So complications mean this is abnormal puerperium, that will be taken in another class. Basically we discussed today definition, changes, and advices. These are the three important things we will discuss. So 6 weeks period. It is not that 3 months, 4 months, 6 months or 1 year. It is only 6 weeks. So you have to observe the mother for 6 weeks following delivery of placenta, when changes of pregnancy reverts back to nearly pregravid state. Never in pregravid state, non-pregnant state, but nearly pregravid state. So unless this normalcy is returned, the risk is there. So if the normalcy is delayed, return of normalcy is delayed, so risk of complication will be there. So that's why usually by 6 weeks time, all the changes reverts to normal, and so risk is over. So after that, the woman will be treated as a woman of non-pregnant state. So all the diseases will be treated like that. But during this period of risk period, so women will be treated separately, and separate complications will be deal with for the puerperium. So changes, basically 3 areas where changes will occur. Number 1 is reproductive tract. So this is the system which undergoes lot of changes during pregnancy. So they will definitely have to come back to normalcy. And the breasts, so which is very important for puerperium, it was not so important during pregnancy. And cardiovascular system, which is the main system which a lot of adaptation occurs during pregnancy, they will have to come back to normal, otherwise different cardiac complication would occur. So reproductive tract, the areas will be uterus, cervix, ovaries, and vagina. One by one. So uterus, usually you see just after pregnancy is over, it weighs about 800 to 1000 gram. So that will come back to pre-pregnant state, or non-pregnant uterus is 60 gram or 70 gram. So from 800 gram to 70 gram, so 10 times reduction that will go, and that is known by involution. So involution is a process of reduction of uterus muscle, reduction of the height of the fundus. So just after delivery, the uterus, if you see the fundus, it will be at the level of umbilicus. You can measure it by the measuring tape, and then the first 24 hours there will be no reduction in height. After that, it will be half inch per day or 1.25 centimeter per day. So if you go on 1.25 centimeter into 10 days, it will be 13.5 or like that. So 13.5 centimeter is the fundal height following delivery. So that occurs by proteolysis. So protein breakdown products will be available. Protein breakdown products will be available in the urine. So the process is proteolysis and process is called involution. So by that rate, the uterus will not be palpable by, oh, this is missing by 2 weeks. Usually by 10 days time, it will become a pelvic organ. So after 2 weeks, if you ask the woman to come for checking whether involution has occurred or not, if you find it is still palpable, that means involution is slow or not occurring at all. You may find that uterus is remaining at the level of the umbilicus. So that is sub-involution. So if the involution is not occurring, at the normal rate, then it is called sub-involution. So, and what happens to the muscle is proteolysis, but what happens to the endometrium? Endometrium undergoes sloughing and discharged as lochia. We are coming to that lochia, and the vessels which are very much proliferative within the muscle, that undergoes thrombosis. So there is lot of vascularization of the uterus that undergoes thrombosis followed by degeneration, and new vessels are formed within the uterus that you can find by histological examination of the uterus following delivery. That has got a medical legal importance. So lochia, the composition is the decidua, sloughed out decidua, the membranes, amniotic membranes, part of the amniotic membranes, lot of membranes are discharged during the delivery, WBC, RBC, and it has a characteristic smell, that is a fishy smell. If it is not a fishy smell, it is a foul smell, then it is abnormal. So characteristic smell is lochia, and the color, these are the characteristics of lochia. Color may be red for first 4 days, that means few blood cells are coming, so that is called lochia rubra. Then next 7 days is lochia serosa, that means pinkish color, and next up to 2 weeks is lochia alba, whitish in color. So rubra, if more than 4 days, more than 7 days, it is abnormal. In serosa and alba, if more than 2 weeks, it is abnormal. So that is the characteristics of lochia. Endometrium is regenerated by 2 weeks, and last is placental area. So this area takes up to 6 weeks time to regenerate. So risk of infection is there at the placental area unless it is covered by endometrium. So that is up to 6 weeks. So and colonization by an organism. So usually the pregnant uterus is free of organism, but after delivery the microorganism ascends up, so it colonizes the endometrium or the uterine cavity. That takes about 72 hours. So up to 72 hours, if you open the abdomen, there is no risk of infection. But if you open the abdomen after 72 hours, you may have run the risk of infection, because those ascending organism from the uterus may travel along the tube into the peritoneal cavity. So usually it was the dictum, if ligation following or sterilization operation following puerperium is to be done, it is to be done by 48 to 72 hours. So 24 hours rest followed by next day if you do the tubectomy, the risk of infection or peritonitis is less. So that is very important. Colonization by organism by 72 hours. Cervix, cervix is 10 centimeter dilated during delivery. So that will gradually becomes narrower, that will be narrower, and its shape will be changed. It was circular before delivery, but following delivery, it will be transverse slit-like. By 2 weeks time, it will be closed. So before 2 weeks, the infection organisms can ascend easily because the cervix remains dilated. So maximum chance of infection is up to 2 weeks. Following that, the chance of infection becomes less. Erosion, cervical erosion, that means migration of the endocervical epithelium outside because of the estrogenic effect. So that erosion by definition is a red area around the cervix. So that erosion may persist up to 3 months. So up to 3 months following delivery, if you find some erosion, that should not be treated. That should not be declared as abnormal, because that is the normal changes which takes time to reverse back up to 3 months. So though the puerperium is 6 months, but if you get the patients at 3 months and that is still it is erosion, that will be not taken as abnormality. So not abnormal. Vagina becomes narrower and rugae appears by 2 weeks, but never to as it was before the the pre-pregnant state. pH is alkaline. So acidic pH of vagina is important to prevent infection. So pH remains alkaline following delivery, during puerperium. So chance of infection is there, and so vulnerable to accident infection. So discussing of all those things is that puerperium is the period during which risk of infection is more. So risk of infection is more. Then the question of ovulation, which was suspended during pregnancy for 9 months. So when this will return? Usually ovulation resumes earliest at 4 weeks, 4 to 5 weeks. So if the ovulation at 5 weeks, so definitely the menstruation will be at 6 to 7 weeks. So earliest ovulation can occur 4 weeks. So up to 4 weeks, no need, there is no need of contraception. But following 4 weeks, the need of contraception will arise, because when the ovulation will occur, we do not know. So non-lactating woman, if the woman is not lactating, then only this stands true. But if the woman is lactating, then the ovulation is unpredictable, because lactation means prolactin level high, which will suppress FSH, LH, and so that will prevent ovulation. The ovary becomes unresponsive because of the prolactin. So a lactating woman, the ovulation is unpredictable, so menstruation is also unpredictable. So that is called lactational amenorrhea. So amenorrhea in a lactating woman is not abnormal, not due to pregnancy, but pregnancy must be excluded. Before declaring, it is because ovulation can take place as early as 4 weeks. So whenever the lactating woman is coming with amenorrhea, your provisional diagnosis is lactational amenorrhea after exclusion of pregnancy, and so that we take advantage of as a method of natural contraception. So natural contraception, lactational amenorrhea method, LAM, is a method. That is a contraceptive method, natural contraception. So criteria is breastfeeding, and that stands up to 6 months. But that is not a very reliable method. Risk of pregnancy is 30 to 40%. That's why we should not rely on lactational amenorrhea. But so even if the woman is running with lactational amenorrhea, we should prescribe another contraceptive to have the guarantee, 100% guarantee against conception. So that is the ovulation. Then about the general examination or cardiovascular changes. Pulse rate may increase by few beats because of stress and strains and reactionary rise. So patient may be given blood, may be given IV fluid. So because of that, pulse rate may be up by 10 beats. That is not abnormal. Temperature may rise also because reactionary rise because of the stress of labor, that is a exercise. So because of the temperature may rise, but and patient may have postpartum rigor about because of this rise of temperature, and rise of temperature may occur on third or fourth day due to breast engorgement. So this is the time during which milk secretion starts or lactation starts. So it takes about 3 to 4 days time. So during which the breast engorgement will be there, start of lactation, and so during that period the temperature may again rise, but in none of the cases it is persisting beyond 24 hours. So to have the patient is having pyrexia, the temperature must persist beyond 24 hours. So if it does not persist, so if you get a temperature within 24 hours, you have to monitor the temperature again after 24 hours to see whether the temperature is persisting or not. If it does not persist, it is not abnormal. Coming to cardiovascular system, cardiac output increases up to 60% because the extra fluid which was retained during pregnancy, that has to be excreted during this period because the estrogen progesterone has come down. So salt and water retaining effect is gone. So it will be excreted via the cardiovascular system. So heart has to pump more. So chance of failure because of the cardiac output increases. So if the heart is in a compromised state, so there is chance of failure. So chance of failure possibly is more during labor and more at the 34 weeks of pregnancy, and this is the time also there is rise of cardiac output leading to failure. So in a case of heart disease patients having valvular disease, having some other diseases that undergoes the risk of failure during the puerperial period. So you have to monitor the mother in a case of heart disease cases following delivery, whether the patient is developing cardiac failure or not. So patient should not be discharged. So by 2 weeks time it will take. So you should not discharge the heart disease patient following delivery before 2 weeks. So by 2 weeks time the cardiac output will be stabilized, so after that you can discharge. Rise of blood pressure in PIH. So pregnancy induced hypertension was there. So there is again chance of rise of blood pressure because of the high cardiac output during this period, and so there may be development of eclampsia, especially during 24 hours following delivery. So you have to monitor the mother for development of eclampsia, or in some cases we give prophylactic magnesium sulfate to prevent eclampsia. That is recommendation is there in case of your PIH patients. Hypercoagulability which was present during pregnancy, so it will also persist during puerperium. So it will take time to revert back. So because of that, risk of thrombosis is there. So risk of thrombosis because of hypercoagulability. Not only that, because of trauma on the leg. So risk of thrombosis and platelet counts also increased. Because platelet count increased, because hypercoagulability persists, so risk of thrombosis there. That is one of the major complications during puerperium and the cause of death also thromboembolism. So all are settled by 2 weeks time. So after 2 weeks the risks are there. So you have to monitor the mother, and WBC count may increase up to 30,000. So count of WBC, high count of WBC should not be taken as a marker for infection, because in puerperium WBC count may rise naturally without infection up to 30,000. So unless there is other signs and symptoms of infection, only on the basis of count we should not take it as a infection. What about the breast? So all the organs undergoes regressive changes, but it is the breast where there is no regression. There is more proliferation in the breast because it is the function of feeding the baby. So size is further increased and vascularity is increased. The duct and alveoli are more proliferated more, grows more. The secretion of milk is initiated. So because of vascularity and milk, the breast is engorged, may feel pain, and breast engorgement occurs on 4th or 5th day. So during this time, the lactation start. In spite of having high prolactin level, placental prolactin during pregnancy, there was no milk secretion. So after the placenta is expelled, then estrogen progesterone gradually comes down. So by 4th or 5th day, the estrogen progesterone, inhibition of estrogen progesterone on the prolactin action is gone. So lactation starts. So that is about the, so lactation, you know, from your knowledge of physiology, 1, 2, 3, 4 phases. The first phase is over during pregnancy. Alveoli and ductules proliferate during pregnancy. That is the first phase. And secretion also is there because of prolactin, but it is not maintained or it is not discharged. Lactogenesis, so preparation of the breast for milk secretion is mammogenesis. Lactogenesis, it is the starting of milk secretion. So that is due to circulating prolactin, and because of the inhibition is withdrawn, inhibition of estrogen progesterone is withdrawn because of the expulsion of placenta. So lack of inhibition by placental estrogen and progesterone. So prolactin start action, and so secretion, milk secretion starts. So next phase is expulsion of milk. So to the milk ductule or lactiferous sinus by oxytocin. এই জল আছে তো? আমি জল আনতে ভুলে গেছি। কবেকার জল? So expulsion of milk to the milk ductule by oxytocin. So that is galactokinesis. And then is galactopoiesis. That is maintenance of milk secretion by prolactin from pituitary. That was the prolactin from placenta. This is from pituitary. The prolactin level is very low in comparison to pregnancy, but still the lactation will be occurring because of there is no inhibition of the progesterone estrogen. So know the lactation, you have to know the anatomy of the breast. So these are the breast alveoli from which the lactiferous ducts are there and lactiferous sinus. Milk production cells is alveolar, lactiferous sinus, and 15 to 20 such ducts are there which is ending at the nipple, from which baby sucks the milk from the sinus. So milk from here, because of the contraction of the monoepithelial cells, and it is discharged into the lactiferous sinus, from which the milk is withdrawn. You see, the suckling suckling causes inhibition of the hypothalamus, which releases dopamine. So dopamine is withdrawn because of the suckling inhibits the hypothalamus. So dopamine is withdrawn. So prolactin was the under the dopamine inhibition. So because the dopamine is withdrawn, so prolactin starts secreting. Pituitary, anterior pituitary releases prolactin, and which stimulates breast alveoli secretion of milk. So that is called prolactin reflex. Prolactin reflex, and because it is dopaminergic action, so inhibition dopaminergic, so dopamine agonists can suppress the milk secretion, that is bromocriptine or cabergoline. So that suppresses the milk. Again, another expulsion of milk, the suckling stimulus goes to neurohypophysis, this is neurosupraoptic paraventricular nucleus, release of oxytocin in the blood from posterior pituitary. So from posterior pituitary, which causes contraction of myoepithelial cells around the alveoli, which causes discharge of milk into the lactiferous sinus. That is called ejection reflex or let down reflex, and this reflex is a conditioned reflex. Without even suckling, the reflex can occur, oxytocin is released by cry of the baby or by presence of the baby. Only seeing of the presence of the baby can stimulate this reflex, because it is mother's brain is conditioned, mother's cortex is conditioned, and lack of oris and lack of sleep can inhibit this conditioned reflex. So that is the cause of inadequate milk secretion, oris and anxieties. So that is about the physiology of lactation. So this is the just picture you see from the cortex. This is the pituitary. So by suckling, that stimulus is going to the hypothalamus, both anterior and posterior. And anterior pituitary, prolactin is coming, and from the posterior pituitary, oxytocin is coming. Not only stimulates the myoepithelial cells, but also the uterus. So because of the oxytocin, the uterus undergoes contraction, and oxytocin also increases the motility of the gut, and so this is occurring through the spinal cord. So spinal cord afferent. So that is about the, and this cortex has also a role because of the conditioned reflex by the from the visual and auditory sensation. So the and anxieties, all those affecting from the cortex to hypothalamus, they are affecting this milk secretion and milk expulsion. So next is our advices. So what are the advices you would like to give during the discharge? So time of discharge not before 24 hours, because 24 hours is a time during which another complication of the following delivery can occur, that is postpartum hemorrhage. I do not know whether the classes has occurred. So risk of postpartum hemorrhage is highest during 24 hours. So if you discharge the mother after 12 hours, then mother, after reaching the home at the night, she will start bleeding. So she has to come back again. But after the 24 hours is passed, the vessels supplying the uterus undergoes thrombosis, firm thrombosis formed at the placental area, especially. So chance of, and the uterus undergoes retraction, not only contraction, retraction also. The chances of relaxation, atony is less, so PPH will be less. So should not be discharged before 24 hours. So in the government setup, the principle is, in all cases, discharge will not be done before 48 hours. But theoretically, not before 24 hours. Rest, what do you mean by the rest? A rest has got the drawback that if you give rest, because thrombosis, chance of thrombosis is there, so it will encourage thrombosis. So ambulation must be there. So early ambulation should be there. Patient will be asked to move and all those things so that thrombosis does not occur. But at the same time, she should be advised to have rest also. Because if proper rest is not taken, the milk secretion will be hampered, inadequate milk. So rest means rest or exemption from all household activities. She can do anything she can like, but she will not be allowed to do the household work. So diet, extra 700 to 750 calorie for lactation must be given to the mother. Or mother will lose weight from the extra fat gained during pregnancy. About 3 to 4 kg fat is gained. So from there, the calorie will come. Extra calcium to be given for milk secretion, because if you do not give calcium during pregnancy, it will be mobilized from the bone, but that store can be returned by the calcium following supplied following delivery. So for milk secretion, because milk is rich in calcium, extra iron supplementation for restoring iron store. So even if the mother is not anemic, but still we give iron because mother has gone some amount of bleeding during delivery, about 500 to 1000 cc. So iron supplementation will be helpful for restoring the iron store. Otherwise, mother will develop anemia following puerperium. So that is about the discharge advice. Then what about the perineum? So perineum may have the episiotomy wound, or there may be no wound, but sterile vulval pad, that is the source of infection. If it is unsterile vulval pad for observation of lochia, for collection of lochia, so otherwise the blade will be soiled, shows that will be chance of infection. So infection will ascend from the vulval area through the vagina, via the vagina, cervix, and go up, causing peritonitis. So care of a perineum is very much important. Cleaning of wound each time after defecation and urination. So perineal area must be cleaned each time after defecation and urination, and application of antiseptic ointment, especially if there is episiotomy wound. If there is no wound, simple cleaning is enough. And antibiotics, if the episiotomy is there, so for the prophylactic antibiotic, we advise for the prevention of infection of the episiotomy wound, and analgesic for the pain for episiotomy wound. Then what about the puerperal exercises? So for prevention of infection, you are giving that sterile vulval pad and all those things. And for prevention of thromboembolism, you are encouraging early ambulation, and for prevention of some backache and from abdominal muscles problem, so we advise, especially for backache, we advise puerperal exercises. These exercises are for back muscles and abdominal muscles. Back muscles and abdominal muscles. So straight leg raising, or for back muscles, the head raising. So these are the puerperal exercises. Mother has to be taught to practice. Breastfeeding advices. So we advise proper breastfeeding and demand breastfeeding, exclusive breastfeeding rather, during the puerperium for 6 months. So that is very important. Advantages and disadvantages will be discussed more details during the neonatology classes. Exclusive breastfeeding is advised. Care of the nipple area, that is also to prevent infection of the baby. So long we are discussing about the prevent infection of the mother. So infection of the baby is to be prevented. So care of the nipple area, clean with not sterile water, but boiled and cooled cotton. So cotton are boiled, and that boiled water, cotton is cooled. Following that, each time one piece of cotton will be taken to clear the nipple area before feeding the baby. So that's the clear of the nipple area. Follow up after 6 weeks. So usually we ask the patient to come after 6 weeks to see whether all the changes has been reverted, but or earlier if complication arises. So this is for breast friendly hospital initiative. So to encourage breastfeeding, exclusive breastfeeding, this is a propaganda launched possibly in I cannot remember 1998 or 2000, propaganda to promote breastfeeding launched by UNICEF and WHO jointly. Exclusive breastfeeding, there are 10 rules for this propaganda. The few are there. Exclusive breastfeeding for 6 months, no artificial milk allowed. Baby should be kept with the mother round the clock to have more effect on the lactation condition reflex. Mothers should be taught regarding proper technique of breastfeeding. Otherwise, the baby will have lot of problem, and hospital staff should be trained to handle the problem related to breastfeeding. So all the hospital staff should be trained like that. So we have to know some drugs. Because when you are prescribing drugs to a lactating woman, the drugs will be passing through the breast, through the milk, and will reach the baby. So it will have effect on the baby. Few of them are important. Drugs are secreted with milk. So antibiotics which you are prescribing to the mother will reach the baby. So that can create resistant infection in the baby. Drug resistance in the baby will be created because of the antibiotics can pass, though small amount is passed in the baby. Sedatives, if you prescribe sedative to the mother, that will pass to the baby, and baby will have more sleepy, will be more sleepy. So sedatives should be prescribed just the baby has taken milk, and after that, so when it will be drug level will be at the peak, it will not be able to reach to the baby. So sedatives should be timed in that way. So purgatives, some purgatives can be secreted through the milk, so that should not be prescribed. So that can pass also. Cabergoline, bromocriptine can cause suppression of lactation. So they are useful. They are used where suppression of lactation is needed, where baby cannot suck, baby is premature, baby is not there. So these drugs are useful. Anti-cancer drugs will pass or should not be prescribed, or breastfeeding should not be given, where the mother is getting anti-cancer drug. Chlorphenical cause grey baby syndrome or like that, so it should not be prescribed to the mother. Anti-epileptic also can have effect on the baby. Antipsychotic, not all, some of the, because if the mother is having psychotic problem, so you have to prescribe it. In that case, either you have to stop feeding the baby, or you have to prescribe the drugs which passes to the milk in a negligible amount. In that case, principle you have to formulate. So contraindications, where the breastfeeding cannot be given. There is no such absolute contraindication, because milk is very important for the baby. That's why all are relative contraindication. Most important is HIV positive mother. So risk of HIV positive mother, chance of passing the infection to the baby is less than 1%. So what risk is there? So all precautions should be taken. So mother should be counseled. If you feed the baby with the breast, chance of infection is there. But if you do not feed the baby has to be given artificial milk. So usually the poor mother, where there is no alternative for artificial milk, cannot be prescribed, cannot be provided, so mother will be allowed to breastfeed the baby with the risk of having infection of the baby. So breast abscess on the affected breast. So other breasts she can feed, but on the mastitis or infected breast, she will not be allowed to feed. So cracked nipple is a painful condition, or sometimes unless the breastfeeding is
hold for 24 hours, the cracked nipple will not be healed. So that in that case also the breastfeeding will be postponed, and especially on that nipple, if it is both sides, then it is a problem. Active pulmonary tuberculosis, because in that case the chance of infecting the baby from the mother is there. So after the anti-tubercular drug is started, after 1 week the breastfeeding can be allowed, but still then there is a risk of pulmonary tuberculosis there. So that is a problem of sucking, cleft palate severe degree, a problem of sucking of the baby. So in that case proper measures will be taken to prevent aspiration. So that is about the contraindication.